All right. Hello, 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 and welcome, welcome, welcome everyone to Help Healing Everyday Life Problems. This is day number 2. I am super excited. I am Dr. Shana D. Lewis, and you guys know me, I'm a licensed professional counselor, a motivational speaker, a counselor educator, a trainer, an advocate. Y'all, I'm just here to serve. I'm here to help folks shift from where they are to where they are destined to be. And I have with me one of my dear friends, Dr. Richelle Whittaker, or as I love to call her, Dr. Shell. Dr. Shell, introduce yourself and let folks know who you are and what it is that you do.
Hi, everyone. Glad to be here again. I am, like Dr. Shana said, I am Dr. Shell, educational psychologist, mental health therapist, parent educator, trainer. I help moms from pregnancy through postpartum to parenthood, and I am excited about today.
Yes, if you missed last night, so last night was day 1 where we covered women and depression, and boy, did we have a great time, didn't we, Dr. Shell?
Yes.
It was awesome. We had 2 very amazing women who shared their stories with us, and we talked about it in so many ways. So it was great. And so this whole conference, this summit is all about mental health awareness. May is Mental Health Awareness Month. And what I know to be true is we don't know what mental health issues we may be struggling with. We don't know what to do about them. So I make sure that we are educated, and that's what this is all about. I'm super excited that today we have a brand new conversation. This one's going to be good, y'all. This is really, really good. We're talking about help our children. Now, if you are either a parent, an auntie, a grandparent, a teacher, an uncle, it doesn't matter who you are. If you have children in your life, you want to make sure you stay tuned for this next hour, because we're going to have a really, really, really great talk. Our guest panelist today is Dr. Jon Stevens. Let me read you a little bit about Dr. Stevens. He is the Chief of Child and Adolescent Psychiatry and Outpatient Services at the Menninger Clinic. He's also an assistant professor in Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He is board certified in both adult and child and adolescent psychiatry. He completed his residency in adult and child and adolescent psychiatry at Massachusetts General Hospital and McLean Hospital in Boston. The thing about Dr. Stevens that I love the most, and he and I have sat on a panel once before I asked him to join me, and he is an amazing, amazing man, and he really has a heart for the children and wants to help. And I'm so excited that he's agreed to be here. I used to work at Menninger actually many, many years ago, and if you're not familiar with them, they are one of the top 5 psychiatric hospitals in the world and have been for quite a long, long, long time. I don't know if that rating has gone up at this point or not, Dr. Stevens, but I know back in my day, it was one of the top 5, and I know it's still high up.
As long as they've had the rankings, Menninger's been on it, and very proud to work here. And we'll have you back. I mean, you can come back anytime you want.
Yes.
But when you do stuff like this, I follow you now.
Oh, isn't that so cool?
Pleasure. Thank you so much. Thank you for going through my CV there. I'm flattered, but it really is about these helping youth, especially here in Houston.
Yes.
There are real pockets. I mean, I'll call them mental health deserts, where you cannot get good services for counseling, for diagnosis, for treatment. And what you're doing, I think, is really kind of not only getting rid of stigma in terms of diagnosis and treatment of kids, but also connecting people in these wonderful ways like technology, using the most advanced technologies we have to do things that I've never done in my career. So thank you for having me.
All right. Well, thank you for being here, Dr. Stevens. Appreciate you for agreeing. So can you just tell folks a little bit about maybe just the Menninger Clinic, because maybe they're in the local area or not, because we had folks last night from all over the country. So just tell folks a little bit about what the Menninger Clinic is, what is it that you do, so they have kind of a background about that piece.
Sure. Menninger Clinic serves mental health disorders. It's really a one-stop shop for people with either simple or difficult treatment-resistant conditions. We see it all. I still see patients pretty much half the day, every day, and predominantly youth, so under the age of 18. And what I see in the office is really a wide variety of conditions. I see conditions that are relatively easy to diagnose and treat, like ADHD, certain learning disorders, some simple anxiety disorders, and then conditions that are more difficult to treat, and diagnosed. That would be mood disorders, psychotic disorders, autism, and then even other less common conditions, and usually a mixture of many. So it's not uncommon for me to say even teenagers coming in with a mood disorder, a substance abuse disorder, and maybe a prior history of ADHD in their childhood years. That is not uncommon at all. And I see people on inpatient side where people have to be, usually under a crisis, like a suicide attempt, or a major kind of event at home, aggressive behavior, getting kicked out of schools, or predominantly outpatient, where people come into the clinic or using technology beam into the clinic and have a consult, have diagnosis, have longitudinal care, whatever it takes. I think that's why I'm proud to work here. Really, we're evolving to really meet people where they are. Even now, doing home visits, believe it or not.
Really?
Into
Awesome.
just a few years ago. Yeah, so it's what is old is new again. And
yeah.
There's really a wonderful staff here, as you know, people of variety. It's not just psychiatrists. It's social workers, psychologists, rehabilitation professionals. I mean, it's nurses, mental health associates, so many people who are devoted their careers and their livelihoods and really their lives. I mean, it's such a mission-driven organization. I think you know that.
Oh, yes.
To take care of people with sometimes the most complex illnesses around.
Absolutely. And Menninger does it very, 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 very well. So I want to jump right in. So let me just give the audience a little bit of some ground rules for how this works. So we'll have our conversation. If you have questions, if you're in the Zoom room, you can type your questions right in the chat box. We will read them and we will answer them before we are done today. If you're live on Facebook, you can also enter questions or comments and we will read them and answer any questions you have about children, about hospitalization, about anything you hear us talk about. Please feel free to ask questions because that's why we have Dr. Stevens here for us to answer questions that you might have. So Dr. Shell, I'll go ahead and defer to you. I know you have some questions that you've been asked by parents and we'll go ahead and start with those.
Yeah, so Dr. Stevens, you mentioned inpatient hospitalization. I've had some parents ask, what does that look like and what would constitute a crisis enough for their child to be hospitalized inpatient?
Yeah, that's a great question. Oftentimes, children and really anyone with a mental health disorder get into a crisis zone, and we know that suicide, especially for our teenage youth, is the #2 killer in this country of youth, only behind accidents. We are worried. Many times we hear things, school shootings and homicide. Actually, over the last few decades, homicide rates in youth have come down dramatically, but suicide rates have stubbornly stayed the same, if not gone up in recent years. And Dr. Lewis, you've highlighted this before as well. So what that looks like is oftentimes an emergency room visit because a school call in a crisis, someone is saying a suicidal thought or a suicidal plan. Sometimes through social media like Facebook or Instagram, they'll say goodbye or say something that's ambiguous. So families are not sure if it's the real thing or friends are not sure. And we'll alert a school counselor, we'll alert a teacher, a trusted friend, a coach, or at home families will feel that they have to call 911 or take their child to a local emergency room. Now, anyone who's ever done this process can tell you that emergency rooms are not set up for kids and teens needing mental health crisis care. And oftentimes they spend hours, and some cases even days, in an emergency room waiting for a bed to open at local facilities. Some of these facilities are not great for kids. They feel, like some of my patients say, like juvie. I think Menninger is very different. It's a therapeutic environment. It does not feel like jail or juvie, as the kids will say. And it's not always driven by insurance. So sometimes insurance will only cover for 2, 3, maybe 5 days of inpatient coverage. And then the child is thrown right back out into the dysfunctional home, dysfunctional care system, or bullying at school or a toxic relationship, any number of reasons, and they're not going to get better. Here, the kids stay on average 3 weeks, either in our inpatient or with something called a partial hospitalization where they can sleep in their own beds at night. And they live with us and get medicine and get therapy, which includes family therapy, get intensive diagnostics, which I could maybe talk about a little bit later, but there's some fantastic developments there. And then there's a plan for them to what's called step down to a lower level of care. which may be home or maybe another form of something called intensive outpatient treatment or partial hospitalization, as I mentioned. It's a very disorienting process, I would say, for families. So I'm not surprised that question's there. In terms of what's your insurance coverage. Some insurances offer very little mental health coverage. Which facilities should you go? None of us, we go around shopping for things. You say, okay, I'm going to look here. I'm going to look online. You get a kind of a cost benefit for, let's say, a pair of sneakers or a new phone, new smartphone. You can't do that with mental health coverage. It's very hard to find out what's good, what's not good. Who is your doctor going to be? And as a result, you're going to hear many, maybe even today, horror stories, frankly, of kids who are not treated well. I think the experience at Menninger is radically different. I'm biased, obviously. I work here. I mean, I do some of this care, but I think that we try to be different in that regard. There are other certain facilities across the country that I also think do a very nice job.
Yeah, Dr. Stevens, you're absolutely right. The whole process of even thinking that your child needs to go to a hospital is very scary for parents. And I don't work with children as much now as I used to, but I have had a few children who come my way recently. And some of the things that they've been dealing with are anxiety. That is a huge issue that I'm seeing with children. Can you speak about anxiety in children, what that looks like, what might be causes of that, and how might we treat that? How does a parent know their child might even have an anxiety issue that needs to be addressed?
Well, sometimes kids really have a hard time even defining what anxiety is. It could come out, especially in young kids, as physical symptoms. They have pain in their belly. They don't want to go to school. They're slow to get up to bed. They're more socially withdrawn. And sometimes families will take them to primary care. They might have some diagnostic tests. Nothing shows up. And it's not even recognized. So I think anxiety disorders, as you're saying, are probably one of the most under-recognized and as a result, under-treated diagnoses that we see in kids. Other conditions are common as well. These are very common and very treatable. A lot of times families are concerned about seeing a psychiatrist like myself because they're worried about medicine and specifically the side effects of medicine. When many anxiety disorders are very well treated, if not best treated, by certain psychotherapies. And that could be anxiety disorders like social phobia, or social anxiety disorder, obsessive compulsive disorder, something called generalized anxiety disorder, and of course trauma-related anxiety disorder, something called PTSD or post-traumatic stress disorder, which kids can have. You don't have to serve in war or something like that to get a diagnosis of PTSD. So there are a lot of anxiety conditions out there. They're not always fully recognized, and I think by talking about it, we bring it to light. And that would usually be a clinical interview with a well-trained clinician who's used to seeing this and diagnosing it. There's some rating scales that we could ask families, teachers, and even youth to fill out to kind of understand what kind of anxiety disorder it is. A lot of times it doesn't fit nicely in a little shoebox. So it might cross several domains. So someone would have some separation anxiety, but then some social phobia and school refusal. These are things that I've heard about a lot from this academic year now. Even though it's ending right now, a lot of families are not sure, can they go back to that school next year? They missed 30 days or something astronomical and might have to do summer school or didn't really make friends or miss their prom or something like that because they're so socially anxious and fearful of being judged or embarrassed in a social situation, for example.
Absolutely. I've seen that actually with children who refuse to go to school. They come up with physical reasons why they can't go to school, but then it repeats for weeks at a time. And then you have an issue with the school because they're missing so many days and parents just don't know what to do. So
I've had parents actually have Child Protective Services arrive on their door.
Wow.
Because the child has a mental health condition but can't go to school or is going home or saying, I vomited in the bathroom, but no one saw it and is calling home. I've had families lose, but the schools report it as truancy, not knowing all times, it's well-meaning, or parents lose jobs because they're getting so many of these crisis calls or their phones blowing up from texts from their kid in the middle of the day, pick me up, pick me up, pick me up. That parents lose a job because you can't be distracted while working. So it really could have dramatic implications for not only the child and their emotional development, but parents and the whole family.
Absolutely.
So, Dr. Stevens, there's a lot, you mentioned medication, and so there's a lot of talk amongst parents about medication and alternatives to medication. So I've heard everything from changing a child's diet to having them participate in sports as an alternative to putting them on medications. What are your thoughts about that?
Well, I really am for a holistic strategy, and oftentimes that is all of the above. I think sometimes this discussion in certain parents' mind, and a lot of that's driven by the media, and that's why I'm so happy to participate today, because we're dispelling stigma right now in this discussion. But it's not an either or discussion. It's really a both and. And I think the earlier parents can get their child to a trained provider to make the diagnosis, the earlier can initiate treatments. And like I said, at least for anxiety disorders, the initial intervention might not be medicine. However, when parents oftentimes are worried, so they delay the diagnosis, or it's just not recognized in the family system, which is very common. It's not on purpose. It's just, or you try to get an appointment, and you get an appointment for a psychiatrist 3-4 months out. By that point, the condition went from mild to moderate to severe. So by the time they show up, let's say here to our office, really the medicine, they can't even participate in the therapy if the child's literally under the chair, refuses to get out of the car. I've had this happen. I have to almost do my initial greeting in the parking lot because the child's so socially anxious or fearful or avoidant or can't separate from the family. Then it's harder to say that medicine isn't the best choice. So I encourage families to think about it. Yes, sports are great. Feeling connectedness is great, whether that's spiritual, with a best friend who's a good influence, whether that's an extracurricular, sports, whatever. I'm all for it. I like to tell my families that, just going on medicine, you don't have restrictions because I don't want them to have so many side effects that they miss school or can't participate in a sport because they're feeling dizzy or tired. I want these kids to do whatever a teenager or a young person should be doing. So and with diet, I think that's where, if anything, you start getting, for some families, start getting a little bit off where the medical evidence says, I'm not sure red dye is going to be linked with that. You could do a gluten-free diet. I don't think there's anything terrible with things. I've heard that a lot. Autistic families with someone with autism. I haven't also seen a lot of benefit, I'll be quite honest. I mean, except for raising your food bill, usually. But I'm not against that. And I work with families. Everyone comes with their own set of what their beliefs, their theories, and it's up to me to kind of work within that. It's not for me to have all the answers, and any of my patients would tell you I don't. But it's about that journey together that I think is to form a collaboration that if things are getting worse, families are at least educated about medicine so they know if they need to make that choice for their child, what they're walking into.
And I think what you talked about, they get to make that choice for their child. And sometimes parents think, well, if I go to the psychiatrist, I think I have to put my child on medication, when really it's an evaluation first to see, is medication even appropriate? Are there other things that we can do instead of medication? Because like you said, we're always looking for the least level of care. So if talk therapy is what's going to be helpful, then that's where we're going to send you, is to talk therapy, not necessarily just prescribing medication. So some folks get a little, I've seen parents, but I don't want to go. They're going to tell me they have to be on this or that, and they get anxious about those things. So thank you for sharing that piece. Another thing that's so common, Dr. Stevens, is the diagnosis of ADHD and ADD. Mm-hmm. And we see it very often come in our practice. Parents are asking, the teachers are saying, this child has attention deficit. Can you speak to the differences between those two diagnoses, as well as how do we know if that's really what our child is going through, or is it something else?
Right. So ADHD is a very common neurobehavioral disorder. And when I say neurobehavioral, I want everyone to listen to that first part of neuro, that it is an issue of brain, either underdevelopment, in some kids of damage, either from early life events. Some kids don't get enough oxygen at birth. Some is acquired with certain head trauma. Or I've seen kids that using stuff they shouldn't be doing, like huffing, taking inhalants, and can have brain damage look like ADHD as well. So there's a lot of different causes, but the most common is just typically runs in families. There's a lot of it's about as heritable as height. So if you're within about an inch of your mother or father in terms of height, or your mother, Shana, and that's normal. Usually you're probably taller based on improved nutrition, but you're not, if your mother's, 5 foot, you're likely not 6'5".
Exactly.
That's just genetics. And, in many cases, I was talking to someone the other day and I said, do you have a family history of ADHD? This older man, was getting diagnosed. And he said, well, it run in your family. He said, it doesn't run, it gallops.
Oh, wow.
And he was like, my dad did this, and my grandfather did this, and my son's this. So now, and then the flavors, there's 3 different flavors, and that the names change over time. So certain disorders were called something back then, and now they're called something different. So manic depressive disorder is now bipolar disorder. What people used to call shell shock or combat fatigue in the military is now post-traumatic stress disorder. And indeed, ADD refers to, as a phrase that we grew up, because that was the proper name, attention deficit disorder. Now we call it ADHD, predominantly inattentive presentation. That's a little bit wordier, and that's what doctors do. You got to make it more complicated, more wordy, but it's basically the same thing. The reality is some people with attention deficit hyperactivity disorder, predominantly inattentive type, are just not bouncing off the walls with energy or climbing trees or climbing couches and have tons of energy and talking fast, but they're just kind of head in the clouds. And they procrastinate, they lose things often, like they've lost 3 book bags, or in adults, their wallet, their keys many times, and they just have trouble focusing. Their spouses will say, you know, I call his name 5 times while he's watching television and never responds, and I yell, and he's like, what? Why are you started yelling out of the blue? And he didn't hear you calling his name the first 5 times. That's inattention. And that's one of the different, let's say, flavors or presentations. There's also predominantly hyperactive impulsive, and the most common is combined, having both. So, you know, conditions can present differently in different people. And I would say a lot of people, particularly young girls I notice in my office, if they don't have the hyperactivity and they're sitting quietly in their chair, but they're failing, are misdiagnosed because they're not disruptive. In these classes of 30, 35 kids, they're sitting, they're not learning anything, but it's impairing their learning, but they're not picked up as much as that hyperactive boy, let's say, because they're not disrupting the class and getting sent down to the principal's office or getting detentions or suspensions. And Dr. Richelle, maybe you could say more about that. I mean, I don't know if you see the same thing with these sometimes 10, 11, 12-year-old girls, sometimes even older, that it's obvious they have ADHD, but they were never picked up, even in a pediatrician's office, because they're quiet or distractible, but they're not disruptive. That 5 or 6-year-old definitely would be picked up very soon these days.
Right, that tends to happen a lot. If you don't have overt behaviors in the school system, you kind of get, you know, you're not causing really any major problems, so you just kind of get looked over. Even if you're struggling academically, it's still like, okay, well, maybe she's just not applying. She's not applying herself, or he's not applying himself. It's not really that there could be something else going on until something major happens. Otherwise, it's just, if it's not overt, it's, well, she's just not trying hard enough. We need to talk to the parent, you know.
I find it helpful when the school gets involved. I mean, sometimes I've heard parents, you know, your child needs Ritalin or Adderall, a teacher saying that's probably not as helpful. That's going to be a step far. But for a teacher to say, hey, you know, I've had 20 years experience. I think Billy's having a problem with sitting and focusing and learning. I think that's a gift by a teacher to a parent. It's not always received like that, but that honestly is very helpful.
Right.
Using the language.
Offended.
Yeah.
But I think using the language that you just used is what would have a parent be receptive. But usually what they get is, I think your child has ADHD. You need to take them to the doctor, and they can't come back until you get them on medication. So
that, yeah, you and I have seen that many times. That puts the family feeling like in a catch-22.
Right.
That they're feeling like they've lost the control, that autonomy over their child. And it is ultimately a parent's decision, at least until 18. That's going to be their call when it comes to medication consent. So it's a tough situation for families. But I think teachers are amongst my greatest allies. When I said about rating scales, one of them for ADHD is called the Vanderbilt. You can all download that now and look at those symptoms. I love to have different teachers fill that out, because parents, especially 2 parents working or a single parent that's very busy, might not see all the symptoms the school does. And that's important.
Gotcha. Oh, go ahead, Dr. Shell.
I was going to say, we have a question from one of the viewers. He says that his son is autistic and very little rattles his cage. His verbal response to adversity is, oh, well, things happen. And the parent wants to know, should they be concerned?
Well, classic psychiatric answer, thanks for the question, is it depends. Again, we talked about anxiety disorders, and I work a lot with developmental disorders, autism spectrum disorders. It's one of my favorite populations to work with. When we talked about the anxiety disorders being underdiagnosed, even more so squared in the autistic population. Once you hear the diagnosis of autism, people don't inquire, is there a co-occurring issue, especially if a child's struggling. They might not always be able to verbalize it, but in more than half of people with autism, they will have a full diagnosis of ADHD. Many, 20, 30% will have an anxiety disorder. And then there's other medical conditions like constipation, seizures, other issues, learning issues. So if a child, in this case, sounds like a boy, usually, obviously, people with autism, 3 to 4 to 1 are boys affected. It's hard for them to verbalize. That's one of the criteria, communication issues. And we need to dig a little bit deeper. So what is the behavior saying? Is a child avoiding? Is a child not making friends, not participating, primarily self-directed? Are they spending too much time on screens or technology? It's fine to do this. This is educational, but a lot of kids have very, what I would call low, empty social calories. And you say, well, I have friends, I play video games with someone in South Korea, and we're both playing the same shooter game. That to me is not the same as a friendship that you could talk about feelings, talk about what's going on. So those are I would say to that parent, it depends. We need to know more. Is that child getting any kind of professional help? Or in a school, is the teacher or teachers raising concern about that child's emotional development? Though I really have more questions for that parent than answers.
And you said something that made me think. The whole video game era that we live in. And so what is it that captivates these children so much? And I know that the DSM is evolving and it changes over time, and possibly is that going to be an actual diagnosis at some point? You think about the children who are, if we look at what addiction looks like, something that they just can't help themselves, they cry if they can't do it, they have all these adverse outcomes because they're just so glued to this technology. Even if it's not just video games, your cell phones and laptops and all of these things. Speak to that and how that impacts our children's mental health, and what's a healthy relationship look like with technology?
Well, I think we're still defining it, because the technology has really moved certainly much faster than any social construct, or certainly evolutionary construct, to catch up with it. We've really only over the last couple decades had this kind of, and not even that long, connectedness, at least through technology. This is a great example of what we're doing today. Earlier in our careers, we didn't have this. You call up someone, or you'd even have consult notes. You write these long notes that you'd mail to providers. Hi, I saw your patient. These are my findings. Those times are gone. And even my patients, even coming into the office, may be something that in a few years is kind of considered an anachronism. It's already old school for some of my 20-year-olds. I have to drive in the Houston traffic to come see you. Can't I just see you on my phone? So I already feel like I'm losing that. But in terms of what's healthy, it's harder to define. But I think we all know what unhealthy looks like. When someone is really spending too much time, and there's so many stories. I would also ask yours. I'll tell a couple of people all over. I'll start with a young adult or an emerging adult who's in his 20s, and he had a trust fund, and he loved to play a game where you're playing the game, but you could spend money buying extra items like swords and capes and spells, for the character on the game. Nothing real, nothing tangible, but it helps you move up into levels. And he spent over $250,000 on this, much of his trust fund, to the point that his fiance ultimately left him. And that was really the moment where it's like, I have a problem. Mm-hmm. That to me sounds like a disorder. Mm-hmm. And the World Health Organization has already identified, I think the DSM, we're a little farther behind, has already identified internet and gaming, problematic internet and gaming as a diagnosable condition. Mm-hmm. So I think that actually the diagnosis will catch up. I think, and in little kids, we also see when they're using it to the point that I've had kids, when the parent says, turn off the iPhone or turn off the video game, throw the TV out a window, assault the parent. That starts to sound to me like just as much any behavioral disorder as anything else. I don't know. I turn it over to Dr. Whittaker, you, Dr. Lewis. I mean, I'm sure you have your stories too. And they're really exploding. It's increasing, these problems. It's not decreasing. Am I just sitting here in the office seeing patients? I don't know about you.
I don't know. Dr. Richelle, you're in the schools. What do you see?
So a lot of what I see is kids who don't know how to appropriately interact with each other because of technology. So the ability to have empathy for others, they're losing it because their relations is a video, or they're, it's not really real. And I've seen a lot of kids who don't really know. So in video games, people die, but they get back up. And so they don't really have a good grasp on what's real. So we talking about healthy and unhealthy relationships with technology. I see more unhealthy things that I do healthy.
And I think as a parent, because I have a son and a daughter who love technology. My son loves this, what is it? Fortnite. I'm like, what do they have in Fortnite that is so enticing? But as a parent, and even with my children, as well as those that I treat or have treated, I call on parents to create the parameters and boundaries for your children. They are not going to do it for themselves. Right. They're going to stay on this stuff. They're going to be so glued and attached to it. And then we can get upset with them for being upset about it or whatever the case is, but we didn't set a parameter, because half of grown-ups are stuck on technology too.
Yes.
To tell the whole truth, like the story example you gave with the young man in his trust fund spending it on video. He was an adult, but still engaged in that. So as parents, we have to set the tone, and I see it so often, and it can have detrimental impacts, especially on the social aspect, because they do not know how to talk to each other. They have this lack of connection, and that's a problem. So that translate into adult relationship issues. You don't know how to really have friends. You don't have social connections. You may be a loner, isolate. I mean, so many things. So it can have repercussions that we don't even think about, because you say they're kids and it's just video games. It's just a telephone. But these things can have lasting impacts over time. So my hope is that parents take the charge to say, I have to set the tone. It's our job. Kids aren't capable of doing that. They're going to do what they like, which is being engaged in this stuff so much. So
I agree with you. I think highlighting that, parents that are saying you can't use your phone, but themselves are looking at the phone through dinner. If there's even a sit down dinner while their kids, sometimes in my office, the parents are doing that. We're trying to talk about major, health care decisions, and a parent's distracted. It's modeling the kind of behavior you want to see from your child, but also knowing, in many cases, I will say, I don't know if you feel this way, I feel this way, the technology is advancing so much, kids have gotten very good at hiding what's going on or what they're sending. It's not as easy at looking as it was in a phone bill and saying that you called your boyfriend 20 times that day. Your parents could see it. This is really easy for them to hide. I mean, a lot of especially unfortunately, these pictures disappear, and parents really are blindsided by a lot of these.
Yeah, I think so. And so just if you have questions, please enter them now. We have about another 20 minutes of our conversation. So if you have questions, go ahead and enter those into the chat box or on Facebook, so we can make sure we get those in before we run out of time. This is so good, Dr. Stevens. I just think that parents lack information. So I have parents that have come to me and they don't know what's going on with their kid. And the school has had an issue, and they'll say, but that doesn't happen at home, because the schools complain. But they don't do that at home. And so I don't know why I'm here. Like, they made me come see you, but I don't see that at home. Is it possible that there are disorders that our children may deal with that only show themselves in certain places, like school, and you come home and you see no symptoms of it? Because I hear that often. Parents get so perplexed by that.
All the time. And I encourage families, and I'm sure you do as well, to stay curious about what's going on. Like any, a problem that begins and it's really circumscribed to one particular area, whether it's home or school, but it's only in one. It's not at grandma and grandpa's house. It's not on the sports field. I breathe a sigh of relief. That's usually has a better prognosis than if the problem's spread everywhere. Almost like a cancer analogy. It's much better if it's small in one little area. If it's everywhere, usually worse prognosis. Mm-hmm. So that's how I would explain it to families, but to stay curious, because it could be a major issue and you don't want to ignore anything. Mm-hmm. And especially if that child was doing well and then suddenly now they're getting multiple teachers or, different behavior that doesn't fit with the child's character, that could be a sign. A lot of times I see that, substance problems generally are not, kids are pretty good at hiding it. And, if they get busted in school, that's something to take note of. Just because, well, I never saw them smoke at home or this or that doesn't mean it's not a problem. Similarly, certain kinds of anxiety or disruptive behaviors. I think we need to stay curious about what's going on. Even mood disorders. A lot of times parents say, I don't see how they're depressed. I heard her talking to her friend last night and she was laughing. Well, that child could be profoundly depressed, but was having just a brief moment where they were feeling okay.
Mm-hmm.
So I encourage families to, stay curious, ask, and look. Don't try to get on the defensive. And I think we've all seen this. They're shocked, and then they get into the denial phase. Well, it can't be. She's always been fine. Or the grades are good. Yeah, the grades are good, but her hygiene's dropped. She's no longer friends with this. She's socially isolated. She quit the sports team. Just because the grades are good doesn't mean there aren't problems, let's say. That's another thing I hear. It's like, well, this one part of their life is good, so I'm not too worried. Well, beware.
Yeah, because it doesn't mean everything is okay everywhere. And I love what you talked about. Parents have to ask questions. Talk to your kids. That's your first line of defense, is just talking to them. We miss that, right? That we're supposed to just watch. No, have conversation. That is critical mass. If you're not talking to your kid, you've missed a fundamental link about their mental health, because they're going to tell you a lot if you just ask. If you just ask. So that's huge. Something else, Dr. Stevens, that you and I touched on a little bit on yesterday when we were chatting, was about when parents have decided that medication is appropriate, they're working with their medical professional to have a medicine regimen for their child. They're taking it during the school year, and now here comes summertime. And some parents say, well, hey, we don't need it in the summertime. We don't need that same level of focus or whatever it might have been, and we want to stop it. Can you speak to what that process looks like and maybe best practices for parents to consider with medication summertime?
Yeah, I mean, the best practices, in my opinion, and I have a strong opinion on this, I think generally that a medicine, especially for focus, let's say, and I think this is what we see a lot with ADHD, should be good enough for 365 days a year. I mean, Christmas morning, anything, just because, like we talked about with ADHD, it's an underlying neurological issue in the prefrontal cortex. We know the area of the brain. And I would liken it to another medical condition, one that I happen to have, which is I also have a focus issue, one of the eye. And so things that are close, I could read fine, but far away, I can't see. It's blurry. That's because my eye is not focusing light on my retina way that the image is clear. So I take a daily correction, which is contact lenses or glasses. Today, want to look good for camera. So, contact lenses till I get up the nerve to get the eye surgery. Mm-hmm. But it's the same thing with ADHD. That just like at the end of the day, when I take my contacts out, my eyes are just as bad as they always were. When you stop the ADHD medicine, the ADHD is unchanged. So if you don't take your Ritalin, Adderall, Vyvanse, and there's so many of them, Focalin out there, it's right back to square one. And in the summer, yes, there's not as much school or academic, but what if that teenager is driving? Do you want them to be unfocused, distracted, while driving, and a young driver, especially on the roads we have around here? I think that's dangerous. Do you want them to be more impulsive or hyperactive at that party when other people are saying, here, drink this, smoke this? I have concerns about that. I mean, ADHD is a all year round condition and needs, in my opinion, unless it's very, very mild, all year round treatment. So, but it happens every year that suddenly I don't hear from a family starting right around now. And then the first few weeks of September, I'll get a crisis call that, Billy got in trouble. I don't know if I'm using that phrase, Billy got in trouble at school or this or that. We need an immediate refill on the old medicine. And I think it's a setup for some kids to failure, because as they get into habits, and if they're used to not taking medicines in the summer or on a holiday or spring break or Columbus Day, when they get to a certain age and they're more responsible for their medicine, they're just not really responsible. They're not sure when to take it. Whereas those kids that are just used to taking the medicine every morning, it's part of their morning routine, whether it's Monday or Sunday, generally stay on it and then have better outcomes.
Yeah, that's really important. Now, Dr. Richelle, when you're in the school system too, 'cause I know you do a lot of testing with children as well, do you find that same thing? I mean, parents reporting that whole thing where we're about to go off and so we'll take a break?
So I hear a lot of like it's the weekend. So parents don't have Monday through Friday, they have them on medication, and then when it's the weekend, they take them off and they start them back on Monday. And I have to explain to them that it takes a while for once you stop something, it's not like an immediate effect, like stopping on Friday and then to start it back on Monday. It just doesn't work. I always say, talk to your doctor. Talk to your doctor. If your doctor didn't recommend it, please don't do that.
I tease my families when I say, why are you giving the teachers all the good behavior during the week and then give it to yourself? Because then the families are fighting with the child who's unmedicated, unfocused, or disruptive on the weekends, and it ruins the family life. I'm not sure why families do that. So I tease them like, don't give the teacher all the good behavior. You get some for yourself too.
That's good.
Exactly. That's a good idea. And I love the way you use the analogy of correcting our eyes and vision, because it needs to be corrected all the time. We need to see at all times, not just sometimes. We need to see all the time. So you want to give your child the best opportunity to feel successful, because the other thing that happens when you remove whatever it is that's assisting your child, whether it's medication, whether it's therapy, whether it's a group of some sort, whether it's some kind of positive activity, you remove that. Now you have a child that doesn't have the resources that they had before, which helped them to be successful, feel confident, feel good about themselves. And then when they start to deteriorate, we wonder what happened. Well, we removed the thing that was helping them. So as parents, one of the things that I hear often is parents feel guilty or that they've done something wrong if their child is suffering in some kind of way, mental health. And so in a way of rationalizing that, they may remove the treatment to make themselves feel better, that, well, you really don't need it, you're doing just fine. But the thing that you remove is the thing that was helping them. And you don't have to feel guilty. You talked about it earlier. There's this genetic predisposition to a lot of different mental health disorders that people may suffer from. So you didn't choose it. You didn't choose that necessarily. So how do you encourage parents in that end, not to feel guilty, not to feel to blame necessarily?
That's where you need the time and discussion to just go through what are the concerns, what are the worst fears, because it could be different. What I hear sometimes is family members will gang up on the parent who wants to do the right thing for their child in terms of what we know in 2019 for medicine. But then there's a grandparent or an aunt who said, oh, I heard that medicine, that's dangerous, because they weren't in this long discussion. So I try to provide education materials, both written, oral. I would refer now to, forums like this where people are learning, gathering information, but that doesn't mean that aunt or uncle who you haven't seen, but you're just seeing twice a year at a holiday, and then, whatever comes out, that child's, parents feel very shamed by that. And then they feel like they're not sure. If your hand is shaking as you're giving that child the medicine, you don't have enough information. You really have to be confident, because if you're not sure about it, the child's not going to feel sure about it. And that's why it really needs a discussion. And usually it's not just one discussion. It has to be several discussions of why we're doing this, and do we still need to do the intervention? And, if the child's improved, why are we going to, pull the rug out from under them right now? Like what's their thinking? And a lot of times parents are making sometimes an impulsive decision, not as well thought out as it could be. Mm-hmm. Then again, if it's a well thought out decision, then it's fine. I support them, because ultimately, it's the parent's decision, as long as it's not medically dangerous. But medicine's just a tool, and you want to know how to use the tool. You want to use it right. Some tools I have in my garage, I don't know how to use. It's probably better that I don't use them, because I'll probably get hurt. But some tools, that's how I would look at medicine. You want to be in good hands with a good provider. Oftentimes therapists even spend more time than I do talking about it. So I collaborate with counselors all the time, both in schools and not, because they're going to check. I've had patients I've sit in the office for an hour with, and then they go to the Walgreens or that, and they talk to a pharmacy tech, and they don't take the medicine because they heard something that scared them. Now, I have that happen all the time. Mm-hmm. And also vice versa, that they weren't sure and they went to the wall and then they talked to someone. So people are looking for different answers in a variety of forms. That's great. But you want to make sure you're getting good information. There's so much information available to us this day. Some of it's good, some of it's garbage.
Right, absolutely. And being able to know the difference is
That's
so,
right.
so important. And so I love the other thing you said about the collaboration of teams, because as a therapist, if I have a child, even an adult who's seeing a psychiatrist, I'm working with the psychiatrist to make sure that we're giving the best care collectively. It's not in isolation. So just know that if your child is in therapy and they're seeing a psychiatrist, connect the two of them to each other. It helps us serve your child better, give you the best resource to make sure we're all working on the same thing in a way that helps your child be successful. So Dr. Stevens, we're just about out of time, but if you want to give just some closing thoughts, if something you want to leave a parent with that encourages them to help their child related to mental health stuff, what would you say to a parent who's listening?
Well, one would be watch this. And if you got to leave, come back and finish watching this, and really think about what, just like any other medical condition, what would you do for that child? So your child had a fever today, you take them. You wouldn't delay. You wouldn't think, you kind of get care. And because there's such shortages, you want to do that as soon as possible and get in with people. Ask your friends. Don't feel alone and isolated. Ask your friend group, ask people at your church, wherever, where they might receive help, because chances are they or their family members have dealt with a similar issue. And then follow through with that and find reputable providers, but then also listen what they're saying and get answers. There's a lot of personalized healthcare that's developing right now in psychiatry that is so exciting. And just like for cancers at MD Anderson, where we look at cancers based on and treat it based on the individual genetics, the individual biology of the cancer, the same thing's happening. And now for conditions like schizophrenia, depression, and others. So we're using genetics, and there'll be even more in future years, so that it's a personalized treatment approach. And that will come to therapy as well. Not all therapy is the same. Not all therapists are the same. So you want to have a personalized approach. You want to have a team. I emphasize that. But you want to access the care as soon as possible. Try to avoid some of the old notions of what diagnosis and treatment used to mean, and focus on getting your child and perhaps yourself the help, because these things are, like I said, run in families.
Wonderful. Dr. Richelle, what would you say in closing thoughts?
I would say use your resources. Use the people in your community who have trusted providers, like Dr. Stevens said, to get information, because there is a lot of information and all of it's not good. And so you want to make sure that when you're making a choice for your kids, that you're using reputable information. So ask the people in your village, ask the people that you know who've been through something similar, to ensure that you're getting the best care and information possible.
Definitely. I mean, at the end of it, if you've heard nothing else, it's ask questions, get information. There's so much available, but you want to make sure you're getting accurate information. There's so much that's inaccurate. So I suggest you seek out professional conversations with folks, because if you don't and you're just getting what lay people think, you're not getting the absolute best options for your child, and your child continues to suffer. Children deal with a lot of stuff. So many times I hear parents dismiss, oh, they're just a kid, they're just, growing pains or whatever. Listen to your children. Watch what they do. Talk to their teachers, and don't dismiss anything that may seem a little bit odd or different. Ask questions. Dr. Stevens talked about being curious about it. You have to, because they're counting on you. Our children's success counts on us as their parents, their caregivers, the folks who are in their world, to make sure we are attending to the things that they need attention to. We got to learn how to help them, but we got to understand what's going on to provide the best help. That's what this talk is all about today, is giving you insight on how you can best help your children be successful. It's possible. Now, Dr. Stevens, just tell the folks how they can contact the Menninger Clinic. How might they access services or resources there if they're interested in that, no matter where they may be?
Sure, themenningerclinic.com, or call 713-275-5400. Again, that's 275-5400. Someone there, our care coordination center, will help connect you to care with me or usually one of my very talented staff. But whatever your issue is, we can kind of help you or point you in the right direction, even if it's not here. And there's LinkedIn. There's a lot of ways to follow up to see what's going on at Menninger. Myself, I follow yours, Shana, all the time. I see what you're up to, like this, and just use the technology that we are today for education, for enlightenment, and to really get the best care for you and your family. So thank you.
Absolutely. My pleasure. If you have any other questions, guys, you can still post these later. We'll make sure we get answers to anything, even if you're on a replay. If you got questions, we want to help you get answers. So thank you guys for joining. Just know that tomorrow night at 7:30, we'll be back at this again for day 3. We're dealing with men and trauma. Yesterday, we're all about the ladies. Tomorrow, we're all about the men folk, okay? We do not discriminate here at all. I think that this has been an amazing conversation. I really appreciate everyone's ability to be here, join us in the chat room and on Facebook as well. So if you haven't registered and you're on Facebook, please go to drshanadlewis.com. Click the link and registration will be right there for you. This is free. You can catch the next couple of days if you haven't caught them already. You guys have an amazing rest of your afternoon. Dr. Stevens, enjoy your afternoon as well. Dr. Shell, you do the same, and we guys will see you tomorrow night at 7:30. You guys take care. Bye-bye.
Thank you.